Thank you very much, Larry. It's be here this morning, and I have to tell you that Vancouver is actually one of my favorite places, and I'm much closer to Vancouver than you think. This is just some pictures from Durham. It actually does snow in Durham every once in a while, which is a total disaster if we're not prepared for it. But I'm kind of an old dog, and I'm stuck in the 70s when it comes to music, and so I like to listen to classic rock all the time, and I like listening to it in my office. And when we moved my office about 5 years ago, the radio station that I like to listen to is can't get it. The reception, I can't get it in my office, and so I used to go on the internet and just do streaming audio. And the problem is in the States, is you may or may not be aware, there's a big thing going on about streaming audio, and there won't patent issues. So long and short of it is the classic rock station I listen to all the time is Rock 101 out of Vancouver. And so I know Bro Jake and all the people, and I know the Vancouver weather, I know the Vancouver traffic reports, I know about the sports, I know Neil McRae and listen about the hockey. I mean, so I'm up to speed on Vancouver. That's right. It's pretty sad, isn't it? But again, thank Dr. Goldenberg for his invitation. And what I hope to do over the next 45 minutes is to give you a very rapid overview of what I think have been some of the changes in stone disease and the surgical management of stones over the last 20 years. As Dr. Goldenberg mentioned, my career has spanned pretty much the generation or the generations of stone disease, if you will. And when I was a resident, we were still doing open stone surgery, and that was the most common thing, or it was the only thing that we did to remove stones. But then in the in the late 70s, early 80s, we saw the introduction of endoscopic surgery. But surprisingly, this only lasted, some would argue this only lasted for a few years, because shortly thereafter we saw the introduction of shockwave lithotripsy. And for the last 25 years, or the last 20 years essentially, shockwave lithotripsy has been the treatment of choice for the majority of stones. But I would argue that lithotripsy is not for everyone, and I think it was from the Mayo Clinic who said it best when he said, well, shockwave lithotripsy is a lot like sex. It might feel good and it might be a lot of fun, but is it right? And I think what he meant by that, and why we say that lithotripsy is not for everybody, is because we know there are definitely limitations of lithotripsy. Depending upon the size, the location, and the composition of the stone, all these factors will impact on the completeness of stone fragmentation, as well as how much of the fragments are completely eliminated. So what we've seen over the last 20 years, since the introduction of lithotripsy, is the pendulum is swung, and it's swinging back the other way now, where we see a lot more emphasis on endoscopic stone surgery because of the limitations of shockwave lithotripsy. And so again, what I hope to do is to very rapidly go through what I consider some of the stages, both in percutaneous and ureteroscopic stone removal, talking about how we access the kidney, how we fragment the stones and perform aggressive percutaneous stone removal, as well as the impact of nephrostomy tube size, and then under the ureteroscopy heading to talk a little bit about the holmium laser. I'll have to talk to you about that because you have one of the world's experts here in holmium laser stone fragmentation. Also ureteral access sheaths and the nitinol devices, and finally management of lower pole stones. Well, if we look at our experience at Duke, what is the current role of percutaneous stone surgery in the age of lithotripsy, if you will? And basically it's due mostly to large stones, complicated stones, patients that have obstruction, patients that have hard stones like cystine stones. Body habitus is the politically correct term in the United States for morbidly obese patients, and of course people who have failed shockwave lithotripsy. And so this is an example of one such stone. Do you guys have a pointer? I left my pointer in my other briefcase. No problem. Well, you can see that in the lower pole of on the KUB, that's a complicated partial staghorn stone. and it's causing some obstruction of the lower pole of the collecting system. Thanks so much. And this particular stone is in this 150 or 170 kilo guy. So not only if we would have treated him with a shockwave and he was a normal sized person, but now you add the fact that he's morbidly obese and you take that complicated stone, you would never be able to render him free. But we were able to, with 2 sticks, get him completely stone free with one procedure. This is what's termed a stay out of trouble stone, and although this is a calcium oxalate dihydrate stone, and some would say, well, we could shock that thing 2 or 3 times and render the patient stone free. We've seen also significant complications with treating this with shockwave monotherapy with a number of residual fragments and Steinstrasse. And so with a single percutaneous approach, we can render this guy stone free and get his collecting system looking back to normal. So when we're on where we're going to make our percutaneous access, a number of factors come into play. Specifically, the size and the location of the stone are the 2 most important things, and then of course we want to know where the position of the ribs are. For a stone that's located at the ureteropelvic junction, we can come in most anywhere in the collecting system. For most of the lower pole stones, we'll come directly into the lower pole. And if we have a complex stone, many times we'll perform a multiple access technique, and I'll talk more about multiple access in just a minute. Now, one of the things you notice from this particular cartoon is that we are accessing the stone through the upper pole calyx. We like the upper pole, and I know that Ryan Patterson's here, and Ryan was brainwashed by one of my good friends, Jim Ligaman, who is a big proponent of upper pole percutaneous access, and I'm sure that you're no stranger to it now if you have both Joel and Brian here. Upper pole access gives you great access to the majority of the collecting system. I also find that it's nice because you're working downhill, and since there's less torquing of the nephroscope, there's less chance of significant bleeding when you're performing your access. And so depending upon where the upper pole is located, you may or may not be above the 12th rib, and in some cases above the 11th rib, and in some cases above the 10th rib. And of course, the higher you get, the more chance you might have of getting an intrathoracic complication, which I'll talk about in just a minute. But the reason we like the upper pole access is that it does allow us to get down the ureter and to take care of the complicated stone. Now, we can oftentimes have problems once you get into the collecting system getting the guide wire down the ureter. And so one of the tricks, one of the things that we use is a torqued catheter. This is called a Comfy catheter. You've also heard the term a Cobra catheter. These are just angled catheters that allow you to erect the guide wire. Close attention to this video. It's a little difficult to see on the fluoroscopic image, but here's the catheter that we've just rotated, and then what we're doing is directing the guide wire down the ureter. You can see this guy has stones in his upper pole calyx and his lateral calyx. We've already come in through an upper pole stick. We've just put our second access in before we've done anything. And so it's our technique, and I think Jim does that as well, is we put our accesses in before we initiate the stone fragmentation. There's less bleeding. We're not under the gun as much to achieve adequate access. So this is an example of a complicated patient where we would perform what I term aggressive PNL with multiple access tracts, a partial upper pole stag, as well as stones in a lower pole calyx. And on the intravenous pyelogram, here's the stone in the lower pole calyx, renal pelvis, and the upper pole stag that's causing obstruction of the upper pole part of the kidney. Now, as I mentioned, we do like multiple access tracts, and here we are. We already have our upper pole tract here, and now we're coming in through a lateral calyx. You can see the fluoroscopic image, sticking the second calyx, again at the beginning of the procedure. And we like doing this because it avoids the need for secondary procedures. It avoids the need for the follow-up sandwich procedure, if you will, the follow-up shock wave, and it may minimize the need for flexible nephroscopy, which although we use frequently, it also can be difficult once you've done a PERC and you have a little bit of bleeding. It's difficult to see what's going on. So in this particular patient I just showed you, we placed two access tracts through the upper pole, one through the upper pole, one through an upper lateral calyx, and once we've cleared the upper pole, notice how our upper pole access tract now will give us a straight shot towards the stone that's in the lower pole calyx. And just by advancing the nephroscope through the upper pole tract, we can reach the lower pole and basically render this patient stone free with two access tracts. Many patients would many would have put a third access tract in, or would have brought the patient back for shockwave to treat that quote-unquote inaccessible stone. And it's been our experience that it remains inaccessible, if you will, if you try to treat it with shockwave. It doesn't do very well. So as I mentioned, we do like the upper pole access, but the problem with an upper pole access is that oftentimes you are above the 12th rib, and the higher you get as you're making your access, the more chance you're going to have of intrathoracic complications. So the advantage of an upper pole access is it gives you direct access to the collecting system. Disadvantage, higher intrathoracic complication rate is injury. We recently reviewed our experience with upper pole access, and these are data from an article which was in the Journal of Urology about 3 years ago, where we looked at 183 patients who had undergone percutaneous stone removal over 5 years. We found that a third of these patients had supracostal tracts, meaning that we went above the 12th rib. About a third of these were above the 11th, and two-thirds were above the 12th, and we even had a few that were above the 10th. The majority, though, two-thirds patients of these 183 were below the 12th rib. These were either lateral or lower pole sticks. And when we looked at our complications, we found that still the most common complication, no matter where you made your access, was bleeding. So about 2.5% bleeding or need of a transfusion. But then you had a risk of lower hydrothorax, and then you could see all the rest, a small amount of additional complications. Now, some of these are related to the location of the stick, and some of these were located just to the fact that we did a percutaneous approach. But when we looked specifically at whether or not we were below or above the 12th rib, notice that if we were below the 12th rib, only 0.5% had intrathoracic complications, whereas 8% of the supracostal sticks had intrathoracic complications. And so our overall complication rate for supracostal sticks was higher. And when we broke it down even further, looking specifically at the intrathoracic complications, if we were below 12, 0.5% complication rate goes up to about 2% if you're above 12, and if you go above 11, you're at 25%. And again, this is due to the fact that you're probably going to get into the chest. And so what we will do, if we have a patient where we know we're going to be above 11 and sometimes above 10, I'll tell the patient right up front, hey, there's a 25 to 50% chance that you're going to wake up with an extra tube in your back, i.e. a chest tube. And Peggy Pearl from Dallas has actually published a very nice study where they now routinely perform fluoroscopy in the operating room, and their fluoroscopic assessment of whether or not they got into the chest actually meshes or jives very well with the post-operative KUB that's performed in the recovery room. And so instead of waiting to get to the recovery room to find out that you've gotten to the chest and the patient needs a chest tube, what we do now is we perform fluoroscopy in the operating room, and if the patient needs a chest tube, we'll do that in the operating room while the patient's still asleep, and that seems to work quite well. So the bottom line from this particular study is that we believe that upper pole access is beneficial, but be aware that you have at higher risk for intrathoracic complications, and lubrication is going to be the key to let them know that they might need a chest tube. Now, once you get to the stone, what's the best way to remove it? And we have a number of options. Ultrasound and pneumatic lithotripsy have been around for a number of years. Also, the holmium laser is available. And we've been particularly excited with a new device that's a combination of the ultrasonic and pneumatic lithotripsy. I think everyone in the room is familiar with ultrasonic stone removal. It was introduced by Peter Alkin back in the late 70s. It has the advantage of not only being able to break up the stones, but also to vacuum out the fragments, and it works quite well for the majority of stones. In addition, I think that everyone is familiar with pneumatic lithotripsy that was introduced in the early 90s. The jackhammer approach will fragment stones of any composition, but the disadvantage is that while you can break up stones of all compositions, you then have to remove those fragments, and so you're left with a bunch of large fragments here that you then have to pull out, which can be very time consuming. And so we've been very excited about a new combination device, a combination of both pneumatic and ultrasonic lithotripsy that allows you to rapidly fragment and then aspirate the stones in percutaneous stone removal. Now, is this available up here, Joel? Have you guys been using this?
We don't have it.
Yeah. So basically, it takes the concept of pneumatic of standard ultrasound. This is a standard ultrasound probe, and what we're doing is hooking up a connector, and then the pneumatic probe, if you will, goes through that connector, through the ultrasound handpiece, and then once we get the pneumatic probe in place, we can snap on a standard pneumatic handpiece. So here's the pneumatic handpiece. So basically, standard pneumatic all in one device, and this little knob will allow the pneumatic probe to come out just at the tip of the ultrasonic handpiece. And you can either step on the ultrasound alone, or you can step on the pneumatic alone, or as in most cases, we'll step on both pedals at the same time and get a combination of ultrasonic and pneumatic lithotripsy. So we've done studies in our lab and some clinical studies looking at this, and in this particular laboratory study we compared fragmentation efficiency, so not only the ability to fragment but also to remove the fragments of a standard pneumatic, a standard ultrasound, and the combination device. And what we found is that if we're looking at the efficiency or the time to fragment clearance, that the combination device gave us the shortest time to completely remove all the fragments as compared to ultrasound alone or pneumatic lithotripsy alone. Also, interestingly, the size of the fragments was significantly less when we used the combination device. Now, I think this is important if you're leaving a residual fragment or a few residual fragments behind. Of course, I'd rather leave smaller fragments than larger fragments, and this is just the size of the fragments that were created by pneumatic monotherapy versus ultrasonic monotherapy. This is the combination approach. We also looked at the combination device in a clinical trial. This was reported a couple of years ago in a prospective fashion. We took 10 patients and 20 patients and placed 10 in each group. We found that the stone burden was comparable preoperatively. In addition, the stone composition was comparable, although there was one COM, calcium oxalate monohydrate, and this was not statistically significantly different. But what was different was the fact that the time to clearance, half the time it took to clear the fragments with the combination device, and the millimeters of stone per minute, or again, the efficiency of stone volume that was removed per minute was significantly higher with the combination device as compared to the standalone ultrasound. And so, hopefully, the Canadian healthcare system being what it is, that you'll be able to get one of these combination devices. It's a very nice way to remove large volume stones, very rapidly fragment them, and then aspirate them at the same time. The ultrasound probe. We had that problem initially, and basically what happened was the ultrasound was actually too powerful. And so what we found, they've done some software modifications, but also we now only keep the ultrasound power at about 70%. And by turning down the ultrasound, it's actually worked quite well for us over the past, say, 6 months. So your experience was not unique.
So we had about 4 that come in.
Well, we have the Olympus as well, like the Olympus, and this one now has been working well for the past 6 months. So I've been very pleased. So with this type of aggressive approach of multiple accesses and combination pneumatic devices, we can tackle fairly complex stones. This is a preoperative KUB of a woman with bilateral staghorn stones, and then for intravenous pyelogram. You can see the extent of her stone disease. Here we place 3 access tracts, upper lateral and lower pole calyces at the beginning of the case. We then start off with our upper pole stick, see how much of the stone we can remove, do the upper pole access alone, and then if we need these lateral accesses, we can use them, and if not, we just pull them out. In this particular woman, we needed all of our access tracts. However, we were able to render her stone-free with the one simultaneous procedure. And so, with an aggressive approach, I think you can tackle very complicated stones on a routine basis. At the end of the case, what about the size of the nephrostomy tube? And this is also something that we picked up from Jim Lingeman in Indianapolis. We used to only use a 22 French Council catheter, or basically a large Foley, at the end of the case, and it was Jim Lingeman who said that he was using routinely a 10 French nephrostomy tube, and so we said, well, why don't we go ahead and perform a randomized prospective trial, and to see which one of these post-operative nephrostomy tubes is going to be better for the patient. And so we took 30 consecutive patients undergoing percutaneous stone removal. The patients were randomized at the end of the procedure to receive either a standard 22 French Council catheter or a 10 French Cope loop. These patients were very similar in their demographics as far as the stone size, the stone burden, where we made our sticks. Basically, same percent of the patients had supracostal sticks, which were more uncomfortable than subcostal sticks, and essentially the same percent had multiple access tracts. And so what we found was that the 10 French nephrostomy tubes, or the patients that had the 10 French nephrostomy tubes, had decreased pain scores in the initial postoperative period. There was a trend towards lower narcotic needs, and most importantly, there was no significant difference in blood loss postoperatively, and there was no significant difference in postoperative morbidity. And this is shown graphically here, where there's a significantly reduced need for, or significantly reduced pain scores in the 10 French nephrostomy group at 6 hours at post-op day number 1 and 2, and then at post-op day 14, no significant difference. And so basically, what do you guys do now, Joel, for post-op nephrostomy tube? Yeah, and actually there was a nice article in the journal this month. Mahesh Desai reported his randomized prospective trial where he basically he compared a small caliber nephrostomy or a standard caliber nephrostomy to a mini nephrostomy to a tubeless, and he found the tubeless was the nicest way to go.
The other thing you can do is the tubeless if it's totally clear and there's no bleeding, but if there's a little bleeding or you're not certain, we just leave the safety down. Bring it back to the standard function tube. If we're unhappy in any way, we can put an internal, external in.
Right.
Or we just pull it.
Right.
Then they have even a smaller tube.
Right, and that's a great idea. The other thing that some people are doing now, Ralph Klayman has reported it, and my ex-fellow Brian Augie, who's out in San Diego, just reported it in the journal last month. They're doing tubeless, but they're using flow seal. They're sealing the tract with flow seal, and so it gives the tubeless with no drainage. It's actually very nice. So you basically put the flow seal applicator right at the edge of the collecting system, and as you pull it back, you fill the nephrostomy tract with flow seal.
One thing that bothers me about that is you because the seal is
right.
Well,
again, these have been two trials now that say it works. Now, those are the two I've seen. What they both do is they leave an internal ureteral stent in. So they put the stent in before they put the flow seal in, so that at least will preferentially drain the urine into the bladder. Something to think about if you're going to do. But that was the way Bellman originally described the tubeless. Was he leaves a ureteral stent in. But anyway, it just shows you that even though we've been doing perks for 20 years, we're still coming up with new ways to do them or new improvements, if you will, of the management of large volume stones. So let's shift gears and talk about ureteral stones. And I grew up in, or didn't grow up, but I spent 10 years of my career. Well, I haven't grown up, that's right. I spent 10 years, my initial 10 years in academic urology in Dallas, and Harry Spence, who some of you probably remember, was the old chief there, and every Friday morning, Dr. Spence used to sit up in the front of the room at his conference, and we used to present different cases and the stones that were shown. He would say, give him a six-pack and a strainer, and that guy will pass that stone, because the majority of stones are going to pass spontaneously, of ureteral stones. 80% are going to pass spontaneously. And in fact, it was very nice data from Miller and Kane from the Naval Medical Center in San Diego, who performed a prospective study of 75 patients, and they basically assessed the possibility of passage of ureteral calculi, and found that the majority of stones less than 5 to 6 millimeters are going to pass spontaneously. Of course, the size of the stone will predict how long it takes the stones to pass, but basically from this particular study, they determined that of the stones that are going to pass spontaneously, 95% will usually pass within 6 weeks. In addition, there have been a number of studies over the past few years looking at ways to facilitate stone passage, and most of you are familiar with this study that was reported in the Gold Journal about 4 years ago of using a combination of nifedipine and prednisone to both reduce inflammation and improve motility within the ureter to facilitate spontaneous stone passage. And in this particular study, they were able to increase the stone passage rate from 56 to 94%. Subsequently, in 2002, an Italian group again performed a randomized prospective trial, again looking at nifedipine and steroids versus placebo, and found that the spontaneous passage rate with the calcium channel blockers and the steroids significantly better in the yellow than if you gave the patient placebo. But what's happened over the past year, or this year actually, at the AUA, there were 2 studies looking at a new paradigm, and that is using an alpha blocker to facilitate stone passage. And this was one study from Turkey Again, a randomized prospective trial, patients with 6.5 to 7 millimeter stones, significantly increased stone passage rate in the patients that received calcium channel blockers, alpha blocker versus placebo, and for stones less than 8 millimeters, 95 versus 56%. And this is an Italian randomized prospective trial also presented at the AUA this year. Again, randomized prospective with an antispasmodic, calcium channel blocker, and an alpha blocker, and a significant increase in spontaneous passage and a significant reduction in the time to passage using an alpha blocker. So if you haven't been doing that, we started doing that at Duke. I think it works. I don't know for sure, but it's probably less morbid than the nifedipine to give them a 2-week course of Flomax, and if it helps them pass the stones, it saves them an operation. We really haven't looked at it. We haven't looked at it in a systematic fashion, so I can't. It's just anecdotal. It's the ones that they pass their stone, they say, oh, it works, and if they don't, I can't tell you. Yes. No, there wasn't. And evidently, if you do the mapping studies of where the alpha receptors are, there are some alpha receptors in the distal ureter along the tunnel. Well, intramural. That's the word I'm looking for. In the intramural ureter, there are alpha receptors there, and so that's the theory. And I think Joel's point was, they're probably alpha receptors distally, but they're probably none proximally, and so is this going to have the same impact if you have a proximal or a mid-ureteral stone? I don't know the answer to that. I really don't have time this morning to get into the debate about what's the best way to treat ureteral calculi, shockwave versus ureteroscopy. There have been a number of randomized prospective trials looking at shockwave versus ureteroscopy, depending upon where the stone is located, the size of the stone, and probably most important, the type of lithotripsy that you're using. That will impact on whether or not ureteroscopy or shockwave comes out ahead. But for purposes of discussion, I'm going to focus on ureteroscopy because it's a heck of a lot more fun to do ureteroscopy than it is shockwave lithotripsy. And I think the results overall are better for managing ureteral stones. A couple words about guide wires. We use all types of guide wires to gain access, but one of the problems with using a glide wire or some of the very slippery wires is that we don't like to work over those wires because once you've found your access, it can be pretty easy to lose it if you try to work over a slippery wire. Maintenance of access, I think, is the most important part of any endoscopic procedure, and I'm still of the belief that access is everything, whether it's percutaneous stone removal or ureteroscopy. As long as you maintain your access, it's difficult to get into trouble. There are a number of new guide wires that have come onto the market over the past 2 or 3 years. These are what I call combination wires. They have a very floppy and lubricious tip, similar to a glide wire. They have a somewhat stiff shaft, and then they have a flexible distal end that allows you to backload them over a flexible ureteroscope. And these combination wires are particularly useful to get around impacted stones. But again, you have to be careful about your access because a guide wire only costs about $12, a ureteroscope $15,000, and a holmium laser $130,000. But I think access is priceless. Because any of you that have done ureteroscopy or percutaneous matter know that when the guide wire is sitting on the floor and you have a hole in the ureter, you see your life pass in front of you, and what you're going to do now at this point. So if you have your guide wire in place, it's tough to get in that position. Our treatment philosophy for managing ureteral stones has changed dramatically over the past few years due to the introduction of the new generation of flexible ureteroscopes as well as the holmium laser. The newer 7.5 French flexible ureteroscopes now allow us to go where we couldn't get to a number of years ago, and we can usually reach the entire intrarenal collecting system with these 7.5 French scopes. And this is an Olympuscope that is our workhorse that we use all the time, and even since that, there are now a number of newer generation scopes. This is the Storch scope with the 280-degree deflection, and of course ACMI's come out with their DUR 8 Elite, which is the dual deflectable scope. Basically, you can get anywhere in the intrarenal collecting system as well as the ureter with all the new generation of ureteroscopes. In addition, I think it's really been the holmium laser that's had the biggest impact on our management of ureteral stones. Not only will it fragment stones of all compositions, but it also is a multi-purpose laser, and it can be used for not only hemostatic effects, but also its tissue effects. We use it for strictures, tumors, as well as for prostatic either resection or enucleation. So again, as I mentioned, Joel, it's like bringing coals to Newcastle, having me here talking about the holmium laser, where you have, again, one of the world's experts in holmium laser lithotripsy. But the holmium laser has been wonderful that it will fragment stones of all compositions. As it is flexible, we can get most anywhere with it. It's very effective in its ability to fragment stones of all compositions. Now, of course, this is a dihydrate stone, so it's cheating to show you how quickly it can fragment that stone. One of the things you do have to be aware about the holmium is that its tissue effects can also be a disadvantage if you're not paying attention. It will not only burn through the ureteral wall, and if you pay close attention right over here, you're going to see us touch the wall of the ureter right there, and although not a significant injury to the ureter, if you're not paying attention, easy to perforate the ureter, easy to cut through the guide wire, easy to cut through the end of your ureteroscope. Basically, you cut through most anything with the holmium laser. So, as long as you're careful, you should be able to stay out of trouble. What's been interesting has been the introduction of the low-power holmium lasers that have come onto the market over the last 3 to 4 years. Now there's a myriad of low-power holmiums that have the major advantage of being less costly than the standard high-power holmium, with the same efficiency or the same ability to fragment stones, and that's because the power that we use for stone fragmentation is essentially, or is the same whether you're using a high or low-power holmium. I don't know what you use for your power settings, but we usually use a low power for our stones, usually about 0.8 and 8. So only 6 watts of power. For strictures, we go up to about 20, and then, of course, if you're doing a laser prostatectomy, you want to crank it all the way up to 80 to 100 watts of power. For low power, for stone use, the low power holmium works quite well, and these are data from a prospective trial that we performed a few years ago. Again, no rocket science in this particular study because the power settings were identical between both the high power and the low-power holmium, but basically demonstrating that our stone-free rate and our fragmentation rates were essentially the same, whether or not we used a low-power or a high-power holmium. Another interesting thing about the holmium is the fact that you can use it in patients that have bleeding problems, and these are data from 2 different studies, one that we reported back in '98 and one that Jim Lingeman's group reported in 2002. That was John Denstadt's group in London reported this with Watterson, and basically a number of patients that had bleeding diathesis either on Coumadin, that had von Willebrand's disease or thrombocytopenia, and the patients were successfully treated with their stones without being treated for their coagulation problems. They were not taken off their Coumadin, they were not transfused, and the advantage is that you can still get away with this without bringing them and doing them under a heparin window, which is very expensive, very time-consuming. When we're doing flexible ureteroscopy, we found that the ureteral access sheath is a very nice adjunctive technique or an accessory to utilize. The access sheath's actually been around for a number of years. It was introduced originally back in the late 80s by Arthur Smith, but reintroduced about 5 or 6 years ago by Ralph Klayman when he came up with the applied medical access. The advantage of the ureteral access sheath is that it comes in all different lengths and diameters, and we place the access sheath up over our guide wire just as we would any other stent or catheter over a wire. We use fluoroscopic guidance to place the access sheath. This is a 12 with a small caliber access sheath. We can see it going up into the proximal ureter, and then once the access sheath is in place, we can take out our inner stylet and then place our flexible ureteroscope through the access sheath and very rapidly access the intrarenal collecting system. We performed a randomized prospective trial a couple of years ago comparing our ability to access the intrarenal collecting system with or without the access sheath. We were able to cut 10 minutes off of our operative time. Not a lot of time, you would argue, but I would then say that that was a 20% reduction in operating time, and in our operating room, that comes to about a $350 cost savings per case. And then if you add the fact that we weren't routinely then using ureteral dilating balloons at another $350 per case, we're now up to about a $700 cost savings per case. And that adds up when you're doing 250 to 300 ureteroscopies per year. So the access sheath does save time and money. We also have found, interestingly, that the access sheath also decompresses the intrarenal collecting system. And so as you're performing your ureteroscopy, your irrigating fluid that you're using to clear the collecting system can very rapidly drain through the access sheath. In another trial that we reported a couple of years ago, we measured intrarenal pressures within the collecting system with and without use of the access sheath. These were patients that came into the emergency room that needed a nephrostomy tube to temporize them, and then when we took them to the operating room to perform their ureteroscopy, we hooked up a pressure transducer to their nephrostomy tubes and were able to measure the pressure in the intrarenal collecting system, and found that with the use of the sheath in yellow, there was a consistently lower pressure in the intrarenal collecting system at all levels of ureteroscopy as compared to if we performed our ureteroscopic procedure without an access sheath. So something to think about if you have a patient with an infected stone or someone that you're treating with a tumor. The other thing that we found is that it's very easy to rapidly place the ureteral stent over the guide wire and through the access sheath at the end of the case if you do need a ureteral stent. And with this little technique, you can very rapidly place the ureteral stent, and we were able to demonstrate another 4 or 5 minute time savings by using that technique. There have been some that have argued that the ureteral access sheath does cause trauma to the ureter, and so we performed a couple of additional studies looking at the access sheath. In one animal study that was performed by one of our residents, we found that although there was a transient decrease in blood flow to the ureter with the larger caliber access sheath, that within a few minutes the blood flow returned, and there did not appear to be any significant ischemia to the ureter with the access sheath. And then in a retrospective clinical study, another one of our residents looked back through 180 patients who underwent ureteroscopy with the access sheath. We found only one stricture in this particular series of patients, and that didn't appear to be related to the sheath, as the stricture was in the proximal ureter and the access sheath was only placed up into the mid-ureter. So we do think the access sheath is not only effective, but it's also safe. And so if you haven't been using the access sheath in your particular practice, I would urge you to consider it. I think it does facilitate flexible ureteroscopy. It saves time and money. It allows for very rapid re-entry, and it does facilitate passage of the stent if you need one. For management of stones within the kidney, we've also found that flexible ureteroscopy can be a very useful adjunct. I think everyone is familiar with the controversy, and hopefully it's not a controversy anymore, about the management of lower pole renal calculi, the debate about whether we should do shockwave lithotripsy or percutaneous stone removal for the management of lower pole stones, and depending upon the angle of the lower pole calyx, this unfavorable angle of a very acute angle, calyx with a very narrow infundibulum, would give you less favorable results than if you had a more obtuse angle and a wider infundibulum. And these are data from the lower pole study group that compared a prospective trial looking at percutaneous versus shockwave lithotripsy treatment of lower pole stones. And for stones in all locations, the percutaneous endoscopic approach provided significantly improved stone free rates, as did shockwave lithotripsy monotherapy of lower pole stones. For you, that for some patients with lower pole stones, even a percutaneous approach is not a good way to go, and in these patients that you might consider ureteroscopy. If you have a patient with coexisting ureteral calculi, a patient with bleeding problems, or a solitary kidney, or renal anatomy that what might make a percutaneous approach difficult, a ureteroscopic approach may provide a very reasonable option. One of the problems, though, that you run into with using the flexible ureteroscope to access the lower pole is the fact that the larger instrument that you place in the ureteroscope, the decrease in the deflectability of that ureteroscope. And these are from a clinical benchtop study that we reported back about 7 years ago, showing that as you increase the size of the laser fiber, you significantly reduce the amount of deflection. But it was John Honey from Toronto who demonstrated very nicely back in 1998 that the new generation of nitinol baskets and graspers were much more deflectable than the previous instruments that we were using, and that you could pass a nitinol basket through a fully deflected ureteroscope. So it's nitinol baskets and graspers that have recently been introduced that now allow us to routinely access stones in the lower pole calyx. And this is shown here graphically, a fully deflected 7.5 French flexible ureteroscope, minimal loss of deflection with a 2.4 French nitinol basket, and significantly more loss of deflection if we use a 200 micron chromium laser fiber. And so we have now routinely managed some patients with lower pole stones ureteroscopically. These are data from a study that we reported back in 2000. Patients that had lower pole stones that we accessed with the 7.5 French flexible ureteroscope. We also used a nitinol basket or grasper in some of these patients. So here's an example of a stone in the lower pole calyx, accessed with both primary and secondary deflection. Notice that with this amount of deflection, you would or should never try to pass a laser fiber through a scope with that much deflection. And so instead what we did is, you can see here's the nitinol basket that we pulled the stone out of the lower pole calyx and basically broke up the stone. Here's the stone. We placed it into a lateral calyx and then broke up the stone in that lateral calyx. I actually have a few video clips showing our ability to pull the stone out of a lower pole calyx and then reposition the stone into an upper pole or lateral calyx, and that allows a much gentler angle of the flexible ureteroscope through which you can pass your holmium laser fiber. For intraoperative footage, a stone in a lower pole calyx. Here we're using a 2.4 French night grasper to grasp the stone. We like using the grasper because if the stone, it's difficult or it's basically impossible to keep the stone hung up in the grasper. But once the stone's in the grasper, we can pull it out of the lower pole. We're coming here through the infundibulum of the lower pole calyx, and as we get into the renal pelvis, we look for the safety guide wire, which is usually coiled within the upper pole. There's the safety guide wire, and we're stuffing the stone into the upper pole calyx. And then once the stone's in the upper pole calyx, we can very rapidly fragment the stone, and we don't have to chase the stone all around the collecting system if we have it stuffed into a calyx, because the ureteroscope will block its egress from the infundibulum. These are again data from this early trial that we performed, showing the types of patients we performed ureteroscopy for management of lower pole stones. These were either morbidly obese patients or those that had failed shockwave, patients with bleeding problems, as I pointed out before, or renal anomalies. And we were able to access all the stones, fragment all the stones. Our stone-free rate was about 84%. So not perfect, but still pretty good. What was interesting, though, is that, first, before I talk about the routine displacement, there is another randomized prospective trial that is being completed. This was another multi-institutional trial performed in the lower pole study group, and these are just some preliminary data from this past year. And these patients had stones that were less than a centimeter in the lower pole, or between 1 to 2 centimeters in the lower pole calyx. The smaller stones were randomized to receive either shockwave or ureteroscopy. The larger stones, ureteroscopy versus percutaneous stone removal. Interestingly, the stone-free rates with ureteroscopy higher than with shockwave in the lower pole, but as you would expect, higher with percutaneous stone removal than ureteroscopy for the larger stones. But again, it's this group that you're routinely going to be doing ureteroscopy for lower pole stones, I would believe, and also the need for secondary procedures significantly reduced with ureteroscopy as compared to shockwave lithotripsy. And again, this is preliminary data from the lower pole study. But one of the ways that you can improve your stone-free rate if you're doing lower pole stones ureteroscopically, we believe, is to routinely displace the stones from the lower pole. And so these are data, again, from our group, where we found that if you treated stones in situ in the lower pole, or if you routinely displace the stones into an upper lateral calyx, if you displace the stones, you had a higher stone-free rate than if you treated the stone where it lay in the lower pole calyx. This was also shown in a randomized prospective trial that was reported by Stuart Wolf's group in Michigan this couple years ago, again showing a higher stone-free rate if you displace the stone. Finally, let me talk about one other piece of equipment or one other accessory that we have been routinely using over the past few years, and that is a device called the stone cone, conceived by Steve Dretler in Boston and popularized by Mahesh Desai in India. This is a device that prevents migration of the stone proximally, and in fact, Joel's group and our group have combined to do a little study using the stone cone in an antegrade fashion, preventing migration of fragments distally during a percutaneous approach. I'll restrict my comments for again, time purposes, just in the ureter for this particular use. Here we place the stone cone proximal to a stone within you can see a very dilated ureter. You can see a little edge of the stone cone right here. And the advantage of the stone cone is that it allows us to fragment the stone in the ureter without having to worry about fragments migrating proximally. Even if the stones do migrate proximally, they're going to have to be pretty small to get around the cone, with the inner lumen here being only 2 millimeters in diameter. Also, there's a protective coating on the stone cone that even if you inadvertently fire the laser on the stone cone, although you'll burn a little bit of it, it's not going to fly into a million pieces. So it is a safe device. The other nice thing about the stone cone is that you can use it to extract small fragments within the ureter after you've completed your fragmentation. Notice that as it comes through a tight portion of the ureter, it partially uncoils and then recoils again to again act as a sweeper, if you will, to remove fragments from the ureter. And I think this is important because the problem that you run into with baskets is that the baskets won't uncoil if they get stuck, and that's how you pull out a ureter with a retained basket. And so the stone cone actually has never had a problem from that standpoint. We've also used the stone cone through the access sheath. So here we are inside the access sheath and pulling out some stone fragments with the stone cone through the access sheath. And then if you look at the ureter after we've completed our ureteroscopy, a little bit of edema, that's where the stone was impacted, but a very clean ureter now after we've pulled out all the fragments with the stone cone. One final thing, and that is about the durability of the flexible ureteroscopes. There's been a lot written about the durability over the past few years, and some have argued that you can only get 5 to 15 uses of a flexible ureteroscope before it has to go out to repair. And so we've asked the question, if we use some of the newer instrumentation that has come onto the market over the past 5 years, i.e. the access sheath, the smaller holmium laser fibers, and the nitinol devices, all of these accessories reduce strain on the ureteroscope. Could we prolong the life of the ureteroscope? And in fact, in this particular trial, we found that we were able to get a mean of 28 procedures per instrument before they had to be sent out for repair. So again, while not making the flexible ureteroscope totally indestructible, I think this data suggests that you can reduce the strain on the ureteroscope if you use some of these instruments. So I hope what I've done over the last 45 minutes or so has given you a very rapid overview of changes and improvements in both percutaneous stone removal and ureteroscopy that have occurred over the last few years that have greatly facilitated our ability to remove complicated renal and ureteral calculi and now continue to swing the pendulum of stone management away from lithotripsy towards endoscopic surgery, providing the patient with improved results with decreased morbidity. So again, thank you very much for having me up here this morning, and I'll be happy to answer any questions. Thank you.
Thank you very much, and I also want to thank Boston Scientific for sponsoring my trip here. Appreciate the support. And I guess I'll ask the first question. How do you decide when you're doing a percutaneous rectal lithotomy whether you're going to go with a single access and use a flexible scope to go after additional calyces or do multiple steps?
Joel, I think it really depends on the size of the peripheral stone burden that you need to get to. So most of the time we're going to do percs. We're accessing a large stone burden. If there is a central large stone burden or an area of large stone burden and a few small residual fragments in adjacent calyces, then I think it's reasonable to stick the large burden, remove that with the standard scope, and then use the flexible scope for the smaller access points. However, if there's multiple areas of large stone burden, then we place multiple access tracks.
And you do that at the outset?
We do it at the beginning of the case, and the reason is because although you can treat the large stone burden, peripheral large stone burden with the flexible scope and the holmium, it's very time consuming and it's not very efficient to remove the fragments.
For the newer our scope back to deflection. Are we getting better deflection at the laser fiber as well as the limitation of the fiber itself?
With some of the new flexible ureter scopes, like the ACMI scope, I've used it a few times, and it has a little more powerful deflection that allows you to deflect that laser fiber. The problem I found, though, is that I think that you're kidding yourself if you think that you can keep doing that to the scope and expect it to keep working the same. And what's happening is that those little wires on the inside of the scope get strained over time, and so if you're really cranking on that lever to deflect it, I think you're shortening the life of that scope. So instead of doing that, why not pull the stone out of the lower pole, put it somewhere else. Literally, it takes 2-3 minutes to do that in most cases, and not only does it, I think it provide you with a better stone free rate, but it probably puts less strain on the instrument.
Two questions. Supervisable access suggested and if so, were they related for height or the site of access?
Fortunately, we didn't have pulmonary injuries. What we mostly do is we drop the lung, or we'll put a lot of fluid into the chest, either blood or mostly irrigating fluid is what it is. I think I've seen 1 or 2 cases of a pulmonary injury. John Honey, I know, reported on pulmonary injury from Toronto, but we haven't seen it. Because most of the time you're accessing the tract with a small needle, so what you're going to do is drop the lung at the outset, so the lung retracts out of the way, so once you get your nephroscope or your dilator in there, the lung's not even in position to be injured.
Great question. When you're trying to displace the lower pole still up into the successful field, how often are you frustrated where you have infinite stenosis or you can't get the stone, you're forced to treat it?
Yeah, it really depends. I mean, occasionally we can't get the stone out of the lower pole infinite stenosis, and if we can treat it in situ, that's what we'll do. But every once in a while, we might have to leave. We can't access the stone in that particular fashion. We have done a few cases where we've taken the homing and incised the neck of the infundibulum. But again, if you can't get the laser fiber to go through the scope to get to the stone, it's oftentimes difficult to get the laser fiber to incise the neck. So it just depends. I'd say the majority of the time, though, probably about 90 to 95% of the time, we can access the lower pole with the flexible scope. It just depends on the size of the stone and the size of the infundibular neck. You're exactly right.